Welcome. It's story time. The story starts here. 1989. Omeprazole was approved by the FDA, the first PPI available. And then, of course, subsequently, many derivatives and relatives were developed, and we even began to use isomers, which might have a little more potency. But this was the step that did this. We now had drugs that could effectively control gastric acid secretion. I hate to tell you this, but when I was a fellow, we had antacids, anticholinergics, and paregoric. Brenda, it was long before you were. But that's how we practiced GI in those days. Yeah, and in fact, there was a resident working with me in those days by the name of Fred Brown. If you look, he's the second author on that GERD Tagamet paper. Anyway, these drugs are crucial to what we're going to talk about today. And the whole world kind of got turned upside down. And here's a recent comment that summarizes some of this. The patient population presenting to GIs for symptoms of GERD has changed because we now only enter the scene after failure of a PPI. And I always like to ask a group of GIs, when was the last time you saw a patient that wasn't already taking a PPI? Pretty unusual thing. This came from University of North Carolina by Dylan and Nick Shaheen, published in Gastroenterology about 4 years ago. So things have changed dramatically from what we do. We deal with this guy. He should look familiar to you. He's in his 50s. His history is that he's had heartburn all of his adult life, and if you try to pin him down when it started, he doesn't know. He can't remember. Maybe when he was in college, when they would do pepperoni pizza and beer, and we'll come back and talk about that. But he's had reflux-type symptoms for years. Somebody put him on a PPI 5 years ago, and the burning component went away. The heartburn went away. But he still had this symptom. After a late meal, after a big meal, he would have a feeling of pressure and regurgitation and a little bit of a cough. So the question was this due to GERD or not? We'll come back to him. So we began to see PPI failures, or many people prefer the term partial responders, if you will. Definition being just that, either no response or a partial response of what you think might be GERD symptoms to PPI therapy. And we'll talk about what might be a GERD symptom, typical GERD symptoms, atypical symptoms. Makes a huge difference. So the shopping list of PPI failures, obviously right on the top is poor compliance. And that's really the biggest problem that you're going to see. People stop taking their PPIs. They don't want to pay for their PPIs. They get better and they stop, and then everything comes back again. Or they take it at the wrong time. It's amazing how many people we see, and every one of you see this, I'm sure, that are put on a PPI twice a day and clearly told, take it 20 to 30 minutes before breakfast and 20 to 30 minutes before dinner. And what happens? When you see them next time, they're taking that second dose at bedtime. You lose most of the effect if you don't take it and follow it with a meal. So very common thing to happen. Or they're taking the wrong PPI. That is to say that everybody doesn't respond to the same PPI to the same degree. There's a lot of inter-subject variability. Or maybe the diagnosis is wrong. You know, we see an awful lot of patients from ENT with suspected GERD symptoms, and some from pulmonary, but ENT is the most active. And I'll show you data in a minute that most, 80% or so, of those people are going to test negative of reflux. And then perhaps they really do have reflux and their acid is not controlled, and you won't know that unless you look for it. And then finally, maybe their acid is controlled and they got reflux, but the reflux is not controlled. That is, they have symptomatic non-acid reflux. And again, I'll show you where that came from. Here's an interesting piece of data. Brad Crow was a medical student at Jefferson that's spent a year in the lab with me. He's now an assistant professor at the Harvard service of the Mass General in GI, fortunately. And we did a little study. Omeprazole had just come out, remember, in 1989. So this is early years of the PPIs. We lined up 20 Jefferson medical students. We called them normals. I don't know how normal 20 Jefferson medical students are, but we called them normals, and we tested them on different timings and doses of omeprazole. This is the data, or these are the data from those individuals taking 20 milligrams of omeprazole twice a day. And this is a percent time that the gastric pH is less than 4. No, it's above 4. This is what you would expect. But only 5 of these individuals had complete deacidification, if you will. 100% of a 24-hour period. Their gastric pH was above 4. Look at the variability between subjects. I had no idea this happened until then. Look at these two guys. You know, they're healthy young people, but they're not responding very well to omeprazole. We watched them take their medications at the beginning and later in the day. Subsequently, a man by the name of Jan Hatlebach from Norway spent a year with us, and we repeated the experiment when the second PPI became available. And now we learned another thing. Here was that omeprazole data you saw before. Here was the lansoprazole data in this group of patients. And there is both inter-subject and intra-subject variability in the response to a PPI. So again, just remind you that if you got a patient who's unresponsive, what's the first thing you do? Obviously, you check their compliance, but then you change the PPI and go to another one. This slide I show you not to show you the biggest study ever done with PPI therapy in GERD, 5,000 some patients in this trial, a randomized comparison of 2 PPIs. And I don't want to make that point either. I just want to show you the healing rates. This is what we're used to. So healing rates of erosive, that's grade 1, of a grade A or grade 1, of erosive esophagitis, 90%, grade 2, 80% or so. When you get down to grade D, of course, it's a little harder to heal them, but most esophagitis will heal with a PPI. And these were single daily doses, 8 weeks of treatment. That's why you guys don't begin to know GERD today as we knew GERD in the old days, because I'll come back to this later on. But Brenda, one of our diagnostic tests was an endoscopy. You don't use that anymore because the patient's already on a PPI and it's healed. So you don't really know whether they were NERDs or GERDs or whatever at any point in the past. But here's, in that same study, again, remember, there's 5,000 patients here. Half of them on omeprazole, esomeprazole, half of them on lansoprazole. This was the sustained resolution of symptoms over the first month. And notice 2 things. Yeah, you know, if you're from one of the drug companies, you'll argue that the esomeprazole was better than our lansoprazole. But most importantly, symptom resolution leveled out at about 60 to 65%, not 100%. This is when we first became aware that there were a large number of PPI partial responders, if you will, or PPI failures. And this was confirmed by this meta-analysis done by Dean and Ronnie Fass out in Arizona, where they looked at published data on symptom response to PPI therapy, non-erosive and erosive esophagitis. Let's look at the erosive esophagitis group here. PPI in regular daily dose, wasn't super dose. Symptom resolution, this was complete symptom resolution at 57%. Here's placebo. 57%, that tells you that 43% were still having symptoms. And of course, not a surprise, the NERD response was a lot lesser. Here, 38% complete resolution of symptoms, so that 62% are still having symptoms. We were learning that PPIs were good, but they weren't perfect in people with GERD symptoms. So this is the algorithm that started to develop in my thinking. Patient presents to a doctor with possible GERD symptoms. What happens today? They get put on a PPI. Whether this is a primary care, an otolaryngologist, a pulmonologist, a cardiologist, they get put on a PPI. So there's a trial of therapy, and if it works, then the diagnosis is kind of confirmed. It bothers me a little bit still. You know, when I went to med school, it was diagnosis precedes treatment. But these drugs are so good that we've kind of bent that a little bit. So persistent symptoms, that's when we enter into the picture here. And obviously, because you guys are all gastroenterologists, what you're going to do is to endoscope the patient, because that's what you do. And the interesting thing is that when you look at the literature, 90% of those are negative. So I would argue to you that endoscopy is a low-yield procedure in these patients. And at least we know that on therapy, and you're not going to stop their therapy, because if you do, they're going to hate you because they're going to have heartburn in about 3 days. If you find eosinophils or something else, obviously you're going to go that way. But this is the group of patients that we have been interested in, as many of you know, the last 10 to 12 years here. People who are poor responders to PPI, who have a negative endoscopy, and we bring them in for ambulatory monitoring of the reflux on therapy. And we'll talk a little bit about that. So monitoring on therapy, you're looking for one of three possibilities. Maybe they're still having acid reflux. Maybe their PPI isn't effective enough. Or maybe they're having reflux, but you've taken care of the acid. We call that non-acid reflux these days. And just maybe their symptoms are not due to reflux. Enter the ENT patients here, if you will. Turns out, Brenda, that a negative test we think is the most helpful thing we can find. Because we can say to the patient, this is not reflux. I know. Well, Joe Richer always asks me, he says, well, that's fine now, but do you stop their PPI? And I said, no, I can't get these people to stop their PPI. They love their PPI. You know? It's just kind of crazy. Anyway, that's the algorithm that we began to work with. Now, let me just remind you why people reflux. When I was a fellow, we were taught this was the mechanism of reflux. You had to have a chronically weak lower esophageal sphincter. And here I'm showing you a pressure of about 5 millimeters of mercury at the valve here. That's 5 millimeters of mercury higher than the pressure in the stomach below. That would be permissive to let anything in the stomach reflux. Acid, pepsin, bile, or the food that the patient just ate. And I'll show you in a minute that GERD, reflux that is a postprandial phenomenon. It's when you fill that stomach is when you get your reflux. But anyway, this is what we believed. For the first 10 years out of my fellowship, we worked with this. We started doing more and more manometry, and we recognized that most people with GERD had a normal LES. Here I'm showing you 19 millimeters of mercury. But if you monitored that over time, you would see these intermittent relaxations. And if you happen to have a pH electrode right there, when this occurred, you'd see acid reflux. We call them, what today? Transient LES relaxation. Believed worldwide to be the primary mechanism of reflux. Everybody buys into that. It makes a lot of sense, actually. We'll talk a little more about that. But keep that in mind. Reflux is occurring because the sphincter relaxes, so that even though you got a normal sphincter, when this happens, you've got no barrier there anymore. All right, seminal study. Some of you know this man, Marcelo Villa. He was a resident at the time, and his companion, a man by the name of Radu Tatuyan, was working, we were in Philadelphia still, was working with Phil Katz and myself. And this was an experiment that they put together. They brought in 12 patients with chronic GERD symptoms, pretty well-established heartburn patients. And they studied them on omeprazole, on or off therapy, looking at the type of reflux. Oh, I have to tell you, by the way, we had just gotten the first impedance probe in the late 90s. This is up in Graduate Hospital. We'd just gotten the first impedance probe, and this probe had 22 sites from top to bottom to measure impedance. Didn't have a pH electrode on it. We put a pH catheter down next to it. So it was kind of a homemade type of thing, impedance and pH. So they had these 12 patients. They brought them in. They put the probe in place. They first studied them off therapy, so they stopped their PPI for a week. And they gave them a refluxogenic meal, which meant in those days that either Marcelo or Radu went to McDonald's that morning and got an egg sausage biscuit and a carton of chocolate milk. That's 61% fat. That'll make anybody reflux. And just in case it didn't, we had them lie on their right side for 2 hours. So big refluxogenic meal, lie on your right side. And here's what they found. Off therapy, total number of reflux episodes monitored by combined impedance and pH in these 12 patients was 217. Off therapy, most of those were non-acid. Because why? Because the meal is buffering the gastric contents. So what's coming up as a pH greater than 4? Over the second hour, it becomes more acidic, and you pick up some of this. Then they took these same patients and they put them back on their PPI and brought them back in after a week of treatment. Repeated the same study, and what happened? The number of reflux episodes didn't change. That number not being significantly different from that number. But what did happen? Well, there's no acid anymore. So all of the reflux now is non-acid. And this is really the story of what we're talking about. Postprandial reflux continues. I'll show you more on that in a minute. Continues. It just changes usually from being acid to being primarily non-acid on a PPI. We had a young man by the name of Wojtek Blonsky, I hope some of you remember. Really a delightful individual from Poland. He was here for 1.5 years with us. And this was a result of one of his studies. He basically was interested in what happens over 24 hours, not just one meal. And basically he looked at a group of patients studied on PPI, 70 of them, and 40 patients studied off PPI. These are not the same patients. So this is data that we culled out of our data bank. On PPI therapy, total reflux episodes per hour. So it's frequency of reflux. On therapy, total over the 24 hours was about 1.7 episodes per hour. Whereas off therapy, it was about 2.3 episodes per hour, and that's just significantly different. But what was particularly intriguing here was what happened after the major meal. So he monitored everybody for 2 hours after their major meal, whether it was lunch or dinner, and looked at postprandial reflux, and they were exactly the same here, at about 4.5 episodes per hour. And the only difference was the composition, of course. on PPI, most of it was non-acid. Off PPI, most of it was acidic. We had a young man by the name of Carlos Zapata spend a month, believe it or not, with us from Peru. Carlos's dad, some of you might know, Carlos Sr. is the most well-known gastrologist in Peru. And I was down there and was introduced to young Carlos, and he wanted to come spend a month with us. And what he did in that month is that he sat in one of those carrels upstairs, and he reviewed 300 studies, 300 patients, 100 off PPI, 100 on PPI once a day, and 100 on PPI twice a day. And what he basically did was to go through the study for reflux episodes documented by impedance. For reflux episodes shown by impedance. I'll come back to that in a minute. And then he did a circadian pattern, that is 6 a.m. to 6 a.m., if you will. And I want you to grasp that pattern because there's a couple really important things here. Again, this is off therapy. So on the off therapy study, notice that there's very little reflux early on. That's because they were fasting. And they came in here and had their pH electrode put in. Then when they had lunch, postprandially, you saw this. And then after the evening meal, this occurred. And then here's the overnight reflux pattern. Episodes per hour throughout the 24 hours of the day. Off therapy. And of course, you see that a good bit of it is acid, the red part of each bar here, because they are not taking therapy. There's some neutralization from the meal, of course. Now compare that with this, which is your patient on PPI, one a day. The curves are almost identical with the same aspects. That is, it peaks up after lunch, it starts to drop a bit, peaks up after dinner, and then falls off overnight. And surprisingly, there's very little reflux overnight in these 100 patients. Twice a day, pretty much the same thing. So we began to learn from these studies.
What's the normal reflux episode for these patients? What would that look like for an asymptomatic?
Yeah. Well, it would look the same, but it would be a lot less. And you would still see the grouping after meals. Because, as I'm going to tell you right now, reflux is a postprandial phenomenon. And it's those transient relaxations that would make that. So you would still see reflux. The number that we use here is less than 48 per day, or 2 per hour. Should be what you find in most normals. So yeah, we all reflux. The patients I question is the ones we study in over 24 hours. There's less than 10 reflux episodes, single digits, if you will. And I'll often turn to the fellow or to Janice and say, when did they have the fundoplication? Because those are the only people you see single-digit reflux episodes in. All right, so PPI therapy and GERD, reflux is a postprandial event. We've seen that over and over and over again. PPI therapy does not change the mechanism for reflux. That is transient relaxations. Why would you expect it to? You wouldn't expect it to, of course. Therefore, PPI therapy does not stop postprandial reflux. It only changes the pH of the reflux rate. People will continue the reflux at the same rate despite being on or off PPI. Now, I want you for a moment to think about pepperoni pizza and beer. And the story is that if I had a patient that was a regular refluxer and I brought him in here and I sent him down and gave him a 10-inch pie and a liter of good dark German beer, what would happen? They'd reflux. Hopefully they'd enjoy it too. Now let me put them back on their PPI for a couple of weeks. Bring them back, same scenario, give them the pizza and the beer. what's going to happen? They're still going to reflux. They just might not have any acid in it. That's what we learned over the years of these things. So let's go back a bit. Pathophysiology of reflux, yeah. The role of acid is well established. Acid causes injury. Acid causes symptoms. We've known that for a long time because all the studies were done before with only acid monitoring. But I just showed you that in many patients, symptoms persist despite adequate acid suppression. So the question that evolved then in the beginning of this century was, could non-acid reflux be responsible? And the obvious answer is, why not? Because the reflux mechanism is not changed by a proton pump inhibitor. So we now talk about reflux that is not acid. And by definition, pH less than 4 is what we've used for 30, 40 years now to define the presence of acid reflux. That goes back to the ambulatory pH studies by Tom DeMeester and his colleagues, going back to the early to mid-70s. I will call it non-acid if the reflux has a pH greater than 4. Some people object to that. They will make the point that if the pH is between 4 and 7, that is chemically still acid, so they'll use the term weakly acidic. But I think it's less confusing to do this, because pH, once you get a pH above 4, it doesn't injure the GI mucosa or the esophageal mucosa anymore. This normal postprandially, that is, stomach contents are often neutralized for 1 to 2 hours after meals, and that effect is augmented if the patient is on a PPI or an H2 blocker. So in many respects, what your single dose of Nexium does in the morning is just a prolong of the neutralization that you get with your meal because your stomach can't pump out acid as effectively as it normally does. So monitoring is what we do. You know, people don't like to have tubes down their nose, but if they want to really learn what's going on, that's kind of the way to do it. And we could talk about Bravo, but we're not going to, because it only measures acid reflux, and you would miss too much. So we put a tube down. And for years we did gastric and esophageal pH monitoring with patients on therapy because we wanted to understand what we had accomplished in those that were not responding well. This will tell you a good deal about how effectively you're controlling the gastric milieu below the sphincter. This will tell you about reflux, but unfortunately only the acid reflux because it's just a pH electrode. So we modified that catheter about 12 years ago by adding a series of metal rings to it. They're 2 centimeters apart, and we put 8 of them on the catheter because that's the way they can engineer it to make it work right. The impedance is measured between each pair of rings. So the impedance measuring sites are at 3, 5, 7, 9, 15, and 17 centimeters above the LAS. Distal reflux, if you will, more proximal reflux here, but still below the upper sphincter. That's what we call an MII pH catheter. That is multi-channel intraluminal impedance, not M2. People often say to me, "You still using that M2 catheter?" Well, yeah, if it works for you, it works for me. So let me show you what it looks like. This is the impedance measurements from that catheter I just showed you. Again, remember, 3, 5, 7, 9, 15, 17 centimeters above the LAS. Baseline impedance here before the reflux occurred varies quite a bit, but it's universally above 1,000 ohms. Impedance is a measure of electrical resistance to a small alternating current that's been applied. So over 1,000 ohms baseline. When the reflux occurs, there's an abrupt drop in impedance down to the baseline. That's because the electrolyte composition of the refluxate is much higher than what's in the esophagus normally. So you get less resistance, more conductance, if you will. There's your reflux. Now, let me show it to you. Disclaimer, I didn't do that. Radu did that. You know, I'm not so clever that I know how to do that. But there's your reflux. And we learned two things early on. I mean, these, again, are studies all done in this institution. We learned two things early on. One was that when reflux occurred, it went up the esophagus very rapidly. We used to think it was slow because most pH monitoring systems only sample once every 5 seconds. Here we're sampling at 50 hertz, 50 times a second. So the reflux went up very quickly. Not a surprise. The pressure in the stomach is a lot greater than the pressure in the thorax. So when the valve opens, up it goes. The second thing we learned is that more than a third of reflux episodes in all patients and normals we studied, more than a third went to the proximal site. So when your radiologist says to you, well, the barium went up to the clavicle, don't be impressed. That's often normal. That's what happens to people when they reflux. Now let me add the pH to it. Remember, there were 6 impedance sites and an esophageal pH and a gastric pH, and here's your pH 4 level, and we've got this reflux episode shown by impedance here. Let's look at the associated pH change. This patient was on a PPI, but they had broken through because look where the gastric pH is, down around 2. And when the reflux occurred, the esophageal pH dropped down to that, pretty much that same level. So that was an acid reflux episode, and I didn't need impedance to see that. But the one on the right, similarly, this patient is on a PPI. Gastric pH is right around 4. Esophageal pH never gets close to 4 here. That is a non-acid reflux episode. That's what this technology has given us the ability to measure. Now, when we put it all together, try to do something that the practicing physician can grasp and understand. Here's the way we write our report these days. So the 24-hour impedance pH metry on PPI therapy, which is what we prefer. First thing we'll comment on is the adequacy of the gastric acid control. And I'll come back to that in a minute. Next, we'll talk about the traditional esophageal acid exposure that Johnson and the Meester build into their score. What percent of the day and what percent of the night is the esophageal pH less than 4? Then we'll total up the number of reflux episodes. And to Greg's question back there, again, we're going to measure both acid and non-acid. And abnormal will be more than 48 total acid or non-acid reflux episode. It's a measure of the effectiveness of the valve, if you will. And then finally, we'll look at the symptom association, frequency and type of symptoms, and their association with reflux. And again, there are many things here that are somewhat controversial. I'll try to cover them as we go along. We use the symptom index as opposed to the symptom association probability. And I'll talk briefly about that. Now, Molly McVeigh did a very nice study. It's been a couple of years ago now, Molly. Basically, I didn't want to present the gastric pH data as strict numerical terms because I didn't want anybody to think that I thought that a single electrode going down in the stomach was totally accurate. So we did a qualitative assessment, or a semi-qualitative assessment, if you will. This is gastric pH, and you can see it's above 4 throughout the 24 hours, and therefore there's no esophageal acid either. Obviously, that would be called excellent. Our next category was good, in which the gastric pH would be at 4 or above most of the day, but would drop down overnight. That's what we call nocturnal acid breakthrough, a well-known phenomenon on PPI, by the way. And there's a little bit of associated reflux. So that's excellent and good. Her fair category basically was, here's your gastric pH again. There's a large amount of breakthrough here, daytime here, going over into the night, and a little bit of reflux associated with it. And poor, it looks like the patient's not taking their medicine, which might be true, by the way. They might not be taking their medicine. But you'd be surprised, even on some of your more popular PPIs like Dexamethasone in an occasional patient, it'll look like this. Now, you don't know that if you don't measure it. You don't know what's going on. And we use the gastric pH to help us decide whether the patient needs to change their PPI. And here's the distribution of the data that Molly did. 374 patients that we studied. Excellent, good, fair, poor. It's interesting. It's almost kind of a normal distribution. And here's the correlation with their intragastric, their mean intragastric pH was really quite good. We call that the gastric acidity score, if you will. Here's an interesting part of these studies. Pete Noss, who was a fellow you guys, some of you remember, did some of these studies also. And this basically shows you that there is a very poor, if any, actually there is some, a very poor correlation between the percent time that the gastric pH is less than 4 and the percent time at the esophageal acid exposure, that is time less than 4. That reflux is not, of course, entirely related to what's below it. It depends on all those other factors, the relaxations of the sphincter, sliding of the hernia, and whatever. So Pete, in his poster at DDW, he hasn't written this up yet, by the way. I think it's lost. The results of this analysis suggest that control with gastric acid as a primary goal for control of GERD is not sufficient. They underscore the importance of the other factors, in other words, motility, etc., as integral contributors to GERD. Let's come back to our patient. So symptoms despite PPI therapy. Again, here's a classic reminder. This is right off the computer screen. Here's esophageal pH. There's no gastric down here. Esophageal pH well above 4. Here's reflux. I think you can see it quite nicely. In fact, I've marked it for you. And oh, by the way, notice here the impedance going off the top of the scale. That's air. Air does not conduct, so you get high impedance, of course. That's what I call the signature of reflux. When you relax your sphincter, you get a little belch that goes up there. And it's a clue that the liquid is coming behind it. And there's the symptom of regurgitation. So this is symptomatic non-acid reflux. Those are the things that we look for. And you get pretty good at it after a while. How many people remember Inder Rainey? Sweet man. Inder is back in Belfast. One of them, for those of you that never met him, he was a fellow here for a couple of years, but never met him. One of the fascinating things about him is that Inder is Indian, as you could probably figure out, but he speaks with a heavy Irish brogue, and it totally disarms people when he gets up to the podium. It's just beautiful to watch. Anyway, Inder was the one that first put together our ongoing experience with monitoring people for non-acid reflux here at MUSC. These were the first 200 patients we studied. We did well that most of them had symptoms on the day of testing. That's a challenge because a lot of people like to put that catheter in. It annoys them enough they go home and they sleep for the day and they don't record any symptoms at all. So we did pretty well. 86% of them had symptoms. So let's look at them as the evaluable patients, if you will. Positive symptom index For non-acid reflux, 35%. Fascinating figure, because as we collected these data and looked at the numbers grow, when we had our first 50, this number was 34%. When we had our first 100, it was 36%. And as it grew, it just stayed right around that figure consistently. I'll show you another collection in just a minute. So symptomatic non-acid reflux, 35% of the patients. The smallest number were people who were still having acid reflux preceding their symptoms, and that was only 8%. These people are all studied, by the way, I'm sorry I didn't mention it, on twice daily PPI. It's been our routine for years that if you're referred in here for an evaluation for is my symptom due to reflux, we would prefer to study them on twice a day PPI. Whichever one they come in with is fine with us. So on twice daily PPI, still 8% of the patients had symptomatic acid reflux. I'll tell you a little secret, some of you know this well, is that when I want to really get rid of the acid in these patients, what do? I add an H2 blocker at bedtime. Now there's a controversy, but you know it works most of the time. So we add the H2 blocker at bedtime. In about a third of these 200 patients, that was true. And if you track them down from here, the number is 0 in those 200 patients. So we combine that H2 blocker at bedtime when we need the effect. Now you've already figured out that the majority of the patients were negative. And again, Brendan, when we first started to look at this, that was kind of a bummer. But it turns out it's really good news. Because now I can tell Lucinda, I'm sorry, Dale, but you know your patient with throat clearing is not having reflux. You need to be looking at another source. So that was the initial study. We published it in Gut, by the way, because Inder was from the British Isles, and I figured he'd get more mileage over there going back. And he's done very well, by the way. Very proud of him. The month before, there was a paper in one of our journals from France. Now, isn't that weird? So the French guys sent theirs here, and we sent ours over the Gut. But Frank Zerbeeb and his colleagues had a multi-center consortium. Smaller numbers, but they had a group of 79 patients that were monitored off PPI. And as you might imagine, they found a lot more acid reflux. This is symptom association probability. I'm going to briefly touch on that if we got time, but we probably don't. 60 patients, the same as ours, studied on PPI therapy. Acid reflux, 20% were positive. Again, we only had 8%, but this is probably because they did not incorporate the nighttime H2 blocker in their study. But look at this. Non-acid reflux, symptomatic, 32%. Ours was 35%. So areas of controversy, just so you've heard of them. Do you do your reflux testing on or off PPI therapy? We do them on therapy because why? Because that's the question a referring physician is asking. Why is my patient still having symptoms despite a PPI? What's going on? Well, the only way you're going to know is to monitor it. So we much prefer to do them on therapy. That's why we don't do Bravo here. We're going to get it, by the way, so the fellows can get some experience. But it doesn't tell me what I want to know. How to document the reflux symptom relationship. That is, do you use pH only or combined impedance pH? Do you do a symptom index or a symptom association probability? You know, at our meetings, we have big arguments about this stuff, as I'm sure you all understand. It's what keeps us all interested. Of course, we know what the truth is. Is it clinically important? That's a big question that people ask. And then finally, of course, what do you do about it? That's a hard one. Because the truth of the matter is we don't have much to do about it. That's why a lot of people yawn when you talk to them about symptomatic non-acid reflux. The symptom index is a simple equation we published. Greg Wiener was one of our fellows. We published 1988. And basically the numerator is the number of times that you have the symptom preceded by a drop in pH. And the denominator is the total number of times that the symptoms reported. And we decided back then, and it's been studied and confirmed pretty nicely, that a positive symptom index greater or equal to or greater than 50% would be considered positive. That's the symptom index. The symptom association probability, which is used more in Europe than the symptom index is, which is used here, basically it's done by the computer, not by us looking at the tracing. It's done by a computer where the entire study is evaluated and broken out into 2-minute segments. And within the 2-minute segments, the computer constructs a 2-by-2 table, reflux, yes or no, symptom, yes or no, and then performs a Fisher's exact test, and a positive symptom association probability is greater than or equal to 95%. It's basically a p-value, if you will. So it's looking at the probability that what you found could happen by chance. We've had many, many arguments about which one's the right one. So we looked at 200 consecutive patients here, where we looked at both of them. The computer spits out the SAP for you. In fact, it spits out both of them for you. So 200 consecutive impedance pH studies, the two indices agreed 72% of the time, particularly in the negative category, which is really good, because now I can doubly say to Lucinda, your patient's cough is not due to reflux. And when they disagreed, it was the same in both directions, so you couldn't really lean one way or the other. An SAP will be 0 when there are 3 or less symptom events, and that's troubling because often there are 3 or less symptom events, and there's just not enough, too small a number in one of those cells to do the Fisher's exact. SAP is shown to be most sensitive and the symptom index most specific. In this one paper that did some outcome studies, they put these people on PPI and then looked at how predictive the SI and the SAP was. So clearly more outcomes data are needed. And then we did this study. Raj Sharma, who many of you know, said, okay, I think the Maney study was interesting, but let's look again now, here about 4 years later, and see whether we're seeing the same sort of thing. So he studied 200, well, he actually had 218 patients, because he pulled patient data until he had 200 that actually had symptoms on the day of testing. It's the 86% thing we were talking about before. Interestingly, 200 patients who were symptomatic during their monitoring, half of them exactly had only non-acid reflux. So we deacidified their esophagus, if you will. The other 100 had a mixture of acid and non-acid. This was absolutely fascinating. Positive symptom index for non-acid reflux, seen that before, 35%. Years later, a handful of acid only and a handful of mixed acid and non-acid. And as before, negative symptom index in the majority of the patients. But now we like that. We recognize that that was a good thing. But one of the reasons Raj did the study is that we wanted to get some more data on just what were the symptoms we were seeing. And this is what that looks like. 200 adults, as I told you, 415 total symptoms. Why is that? That's because on the monitor, you have your choice of 3 different buttons to push. The big one for your major symptom, and then 2 smaller ones for associated symptoms. So we could have had up to 600 total symptoms here, but there were 415, and this was the distribution. The most common symptoms were heartburn and throat clearing, a typical symptom and an atypical GERD symptom, if you will. Then came regurgitation and cough, again, typical and atypical. Chest pain we tend to put in the typical symptom group, and the others and the nausea were up here in this group. But it was interesting. It was about half typical and half atypical symptoms. Here's the others here. We then looked at the symptom index positivity rate by symptom. Heartburn and regurgitation, 50% or more of the time, the symptom index was positive. A little bit disappointing, particularly for regurgitation. I mean, I can understand what people call functional heartburn, and we'll talk about that. But functional regurgitation, I don't understand that. But that's what the data showed. And then interestingly, as we looked at some of these other symptoms that were smaller numbers, we were interested in these, which are the two classic atypical symptoms: cough and throat clearing. About 20% positive. We'll come back to that, because that, again, gives me the assurance to tell my referring physicians with cough, throat clearing, atypical type of respiratory symptoms, that 80% of the time they're going to be negative. And you could argue, why bother to test them? But 20% of the time they're positive. And I'll show you that you can do some good there. Let me skip that because we're running out of time. And just come back to this point again. So here were typical GERD symptoms. This is Maney's data. This is the original 200. Typical GERD symptoms, there were 99 of them. Non-acid reflux, 48%. Acid reflux, 11%. So 59% of these individuals had a positive on the monitoring for symptoms. 59%. Now, some of my colleagues over the years have said to me, I don't need your test. I'm a good doctor. I can tell who these people are. And my response has always been, well, if you don't mind being wrong 40% of the time, then go, break your back. Atypical. Again, we've seen this before. 78% of these people with cough and throat clearing were negative. So you can almost take that to the bank. But you can't really ignore it, can you? Because there's a group here, and there's a group of people with chronic cough. And this is a kind of a worldwide phenomenon that have reflux and respond very well to treatment with it. So those are kind of the breakdown. Now, let me show you a couple other things, and then we'll quit. Andre Smout is an investigator in the Netherlands. Bas Woesten, one of his fellows. And back in the 90s, they did a very unique study on a small group of reflux patients where they put a single catheter down with electrodes at 3, 6, 9, 12, and 15 centimeters, looking at the distribution of reflux. This is acid reflux because it's only pH electrodes. But it's extremely interesting. Notice at the 3 centimeter site, there's reflux here. This is a pH 4 level. Reflux here, and it just starts to clear, then it happens again. That's what we would call acid re-reflux these days. At 6 centimeters, you got the same thing, really. The total duration of time, pH less than 4. When you got up to 9 centimeters, you lost this. So you only saw that early major reflux. Same thing at 12. But this is the one I want you to take home. 15 centimeters above the LES. That reflux is identified, but it doesn't go below 4 anymore. It's been neutralized and mixed with whatever's in the esophagus at that point in time, so that even it is that same reflux episode, if you got an electrode, a pH electrode up there, you would not identify it. So be wary of all the interest in proximal monitoring, because it often doesn't tell you what you think it's telling you. Interesting study. One of the questions I asked is, what's the importance of all this? Well, these are our cough data. This is, of course, a positive study for cough. Here's the esophageal pH up around 7 to 8. Here comes the reflux shown by impedance, going all the way to the proximal esophagus. There's a cough occurring right afterwards, a positive symptom association. Radu did this before he went back to Switzerland. He culled 50 consecutive patients with chronic cough that we had studied here. And he did what I just told you, impedance pH monitoring on either BID, 32 of them, or BID plus a nighttime H2 blocker, 18 of them. And that's about the ratio of what we have here. Positive symptom index for non-acid reflux, 50% or greater. In 13 of these 50 patients, that's 26%. I just showed you that cough was around 20% or so in Raj Sharma's data. But it's there, and they're real, and you can make these people's lives eminently better. These are people that don't go out to the restaurant anymore. They don't go to church. They don't go to the symphony because of their chronic cough. 6 of those, David Adams did a laparoscopic Nissen fundoplication on. Mean follow-up 9 months. They were all asymptomatic and off their PPI. And trust me, very happy people. So you need to at least look for it. That's, of course, uncontrolled. Laparoscopic Nissen may be successful in patients with atypical GERD who have failed PPI therapy if you've got a positive symptom association for non-acid reflux. That was the conclusion of that. And then this really interesting piece of data by Jason Roberts, what he did was identify patients who had 5 symptom events that were positive for reflux. That is, they were all preceded by reflux. 10 of them it was a cough, 10 of them it was throat clearing, 10 of them was regurg, 10 was heartburn. So he had 2 atypical symptoms and 2 typical symptoms. And he had a total of 50 for each, 5 symptom events, 10 patients each. Then he was blinded. We blinded him, and he read these traces, completely blinded, as a symptom association with reflux, because we were, again, curious about the proximal extent of the reflux aid. And that's what this graph shows. We monitor, remember, at 3, 5, 7, 9, 15, and 17. 3 and 5 are used to identify that there's a reflux episode. Then we looked at the more proximal sites. And the 4 bars just represent the 4 symptoms we talked about. The message is they're really the same, particularly here. Look at 17 centimeters. That's cough, 50-some% of patients. That's throat clearing, 50. Regurgitation, not a real surprise. A little more proximal, but not significantly so. And heartburn, about the same. So we can't show any data from here anyway that these atypical symptoms are associated with more proximal extent. So when I talk to the ENT community, they love to see this, of course. Non-acid reflux and extraesophageal symptoms, I always tell them there's good news and there's bad news. The good news is, you can find a positive association between their symptoms and reflux often, but in most cases, up to about 80% are going to be negative. And in those people, you need to be looking for another etiology. And I think little by little, the ENT community is coming there. I think I'm going to stop there because it's time to go home. And we'll do another time, if you're interested, on what do we do about them. This is the hard part, so I'm quitting. And thank you.